I have the task to discuss or show you some data on how we live between adventure of mountaineering and doing science. And let me start the outline. I will show you how it was in early times. And then I want to discuss research setting in high altitude medicine at the present, what we have as possibilities, and then go into the question, we do research that we should distinguish between cause and effect. You all know probably this paper from Peter Hackett. Peter Hackett was 2 years in the Himalayas, in the Khumbu area. He certainly had a great time. He did a lot of climbing, but he also did some major contributions to high altitude medicine. One was he founded the Himalayan Rescue Association, and the other is he sampled data on acute mountain sickness in about 300 trekkers, went back to Chicago, got to, together with Drummond Rainey and another colleague, and they put published this first paper on the incidence, importance, and prophylaxis of acute mountain sickness. That triggered, amongst others, research in the Margarita Hut. Another group is the Birmingham Medical Research Expeditionary Society. One of their famous papers, as you see here, a study in the Andes. As they were up at 5,000 meters, they took prophylaxically acetazolamide and placebo. You see you have a better oxygenation with acetazolamide, and you had less acute mountain sickness. So one of the first studies showing in the field, okay, I see what you want. Then let me turn this. Okay. Proving the efficacy of acetazolamide for prevention of acute mountain sickness. And I knew Joe Bradwell quite well, and he explained me their philosophy. We are doctors. We have always good ideas for finding support for our expeditions. So still, it was a combination between, or actually it was mountaineering, and the spin-off was some publications. This also was explained to me by Oswald Oels. Oswald Oels once, I think he was on Churu, diagnosed pulmonary edema at an evening, and then he had read papers about PEEP, and so he put on PEEP, and in the next morning he was in coma. And he wrote a letter to the Lancet showing negative side effects of PEEP, or reporting. And he told me once, you are doing something wrong if you are not bringing back at least a letter to the editor from an expedition. So that was the setting around the 1970s, early 1980s. And we have a Nobel laureate that in '64 already sang about the times they are changing. And about 30 years later, this also happened to high altitude medicine. And I think we have several issues. One is the political and scientific environment. We all know it. It's hard to get money. There is strong competition for acceptance, also at universities. You have rankings, you have impact factors. You are analyzed by how much money you can raise. That's the political side. And the problems from the medical side is we are a multidisciplinary field. And we have very few institutions. The UROC was one. My institution in Heidelberg was another where you could do research as a main purpose. The research in high altitude is usually done along the side as a hobby. When it goes into funding, there is no market. And unfortunately here in Europe, although we have the Alps, it's not a big health impact in Europe. Mountains, except perhaps for the militaries that have to go abroad in fight in Afghanistan. And so far, perhaps, Dan is proving us wrong. There's little significance for low altitude medicine, so we have a rather weak position. We have one strength, but that doesn't touch our field of mountain medicine. That's anoxia-hypoxia research is very important to understand the whole mechanism of regulation in cancer, in cardiology, in stroke, and so on. So we have to work together with them. But they are looking at anoxia or very low levels of hypoxia. What we are looking at when we get mountain sickness and the pulmonary edema is something quite different. So we need to be very competitive. And it is very important that the research question and not the climbing ambition should determine the study setting. And fortunately, just recently, the group of the URAC put together an expert group and published this data, this paper, and which they call Strengthening Altitude Research, and they give regular rules or recommendations for how to report high altitude data. That's very important. But before you can report data, you have to perform studies. And I think it's even more important to think about how we perform studies. And that's my reason now why I go into the different settings and show you advantages, disadvantages of these settings. So we have the trekking expedition setting that was just introduced. We have research stations in the Alps. We have them in the Rocky Mountains. And don't forget, we have hospitals at altitudes between 3,000 and 4,300, 500 meters. And we are going to hear one example today of studies that are performed in a hospital in Kyrgyzstan that are excellent opportunities to do high altitude research. We have hypobaric chambers and we have normal baric chambers. So I will go into these. When we look at trekking and expedition, the advantages are you can go to very high altitude. You can study acclimatization processes. You can involve large groups, primarily because trekking and mountaineering is attractive. And if you offer some benefit from participating in a study, it's easy to recruit people. You can do very well drug studies. And of course, you have the fun of mountaineering. And I think one of the first studies that, and now then you can decide how much science, how much mountaineering do you want. And the Amory expedition, American Medical Expedition, Research Expedition to Everest, was completely devoted to a scientific protocol. And they stuck to that protocol. And of course, one of the most important or most famous measurements they did was alveolar, sampling alveolar air on top of Everest and analyzing the PCO2, and the PCO2 was 7.5, which anesthesiologists and other people, that can't be true. We can't live. So this triggered a lot of research afterwards. And of course, when you are on Everest, when your name is West, you can have a paper with an N of 1 in science, as it was published here. The disadvantages are you're rather limited in your equipment, though we have seen that Dan Martin is now able to bring quite advanced equipment to base camp. You have vulnerability of the protocol because of external factors. You ascend at a very slow rate, so it's not an ideal setting to study acute illnesses. Logistics are complicated, and you have high costs. You need good sponsors for this. I'll show you one of protocol deviations that can happen. It's a study of Konrad Bloch. It's the first study that prospectively looked at the effect of slower ascent on acute mountain sickness. But when you look closely, you see this is the group that goes slower, faster, and the rings are the ones that go slower. And you see here weather prevented to go all the way to the top, and so it switched around the slow group and the fast group, which made analysis a bit more complicated and the data not so completely convincing. Now, I show you an example of how you can fail even when you devote an expeditionary setting completely to science. What you see here is the mountain range from Eiger of the Bernese Oberland, the Bernese Alps, and the plan was to look at high performance of alpine mountaineers that climbed from Eiger to the Schildhorn. It was a group of Swiss internists that ran the study. They wanted to look basically at metabolism and fluid balance. And one of the errors they did, the study was performed in the first half of March. So that's one error. And the next is, of course, it was a very small group. This is the photographer who also was a mountaineer, and these are all professional mountain guides. The one that triggered the study was actually the most famous. It was Tony Hibeler, who did the first ascent in the winter of the Eiger North Face. So it was a small group, and it was in winter. And it had snowed before they started, and it took them, usually the Mittellegge Ridge, you do in half a day, these mountaineers. It took them 3 days. And to see how the conditions were, since it was a metabolic study, they had to carry their urine across the Mittellegge Ridge, and they had to register everything which they ate. It was actually perfectly prepared. But it was so heavy snow they couldn't advance. And then the most famous of them collapsed after Jungfraujoch. They had 1 or 2 days for recovery in the Jungfraujoch. In the Lauitor, he collapsed. He had to be flown out and hospitalized. It was Tony Hibeler. And so they had to stop the study, and they had to descend to the Legend Pass. So if you are too ambitious and you deal with too big celebrities and with too much prestige, you can fail. If you are interested, this is a booklet that I can recommend you. There's only one paper in a probably peer-reviewed journal. The reference is here. Now let's go to the research stations and huts. You know, in the Alps, we have the Margarita Hut, the Wallow Hut are the highest in the Rocky Mountains. Here, this is Pikes Peak. You can drive up by car here. It belongs to the American Army. Advantages are accessibility. You can transport better equipment. You have electricity. You have rapid exposure. You can study acute mountain sickness and hate. You have little protocol deviation. You can do demanding protocols, and you have much less time commitment than when you go on an expedition. The disadvantage is it's only short-term studies usually. You usually have small groups. And with the mountain refuges, we run in troubles now. Competition for mountaineers, availability and regulations start to make problems. When you go to the hypoxic chambers, this is the upper end, high-end hyperbaric chamber. That's at Natick, a several unit chamber where they performed, can I have something to drink? Where they performed Operation Everest 2. So they simulated an ascent to Everest within 40 days with about, I think, 6 or 7 subjects. Yeah. On the other hand, you have low-end normobaric chambers that often athletes use for training in hypoxia. You have nitrogen generators that are here. You have no control of CO2. And you can have high-end, like some of the athletes have, and we had in Heidelberg. This is a hospital room. This is from the outside. You see here is a control panel, and you can regulate CO2, and you have a continuous control over what's happening. Now, in hypoxic chambers, there are advantages, disadvantages. The advantages, again, it allows technology that's available in the hospital. I think Justin Lawley will show us what you can do in such chambers with modern equipment. Then it's an artificial environment, but it's a very controlled environment. It's the only environment where you can have double-blind settings. It's a boring environment, particularly for mountaineers. And also, don't forget, it can be a frightening environment. If you have a small hyperbaric chamber, you have noise from the compressor, and you are locked in. So you may have an additional psychological stressor, which is never discussed in these studies. And there are two other issues which I want to discuss with you. One is exposure, and the other is difference between hypo and normobaric. Exposure time is shown here. These are data of 308 people that were not acclimatized, that were brought to 2,000 up to 4,500 meters. And with little or more activity, low activity is dashed lines. And you see, this is the AMSC score. It is at maximum at about 20 hours. So when we do studies, and often in normobaric, normobaric chambers, especially when they are at the low end, you have an exposure of 10 hours. You're never at max for AMS, and you have to remember that. So you should go over 20 hours. The other question is there a difference between normobaric and hypobaric setting? Yes, when you measure ventilation, when you look at renal response, there are physiologic differences. The question is, are these really clinically relevant? And there are some small studies using small numbers lasting 8 to 10 hours that show a difference between hypobaric and normobaric in favor of hypobaric. I took our data. This is the Lake Louise score, self-assessment. This is clinical assessment, and these are all the items of the AMSC scores. And it's two groups. In black, it's normobaric hypoxia. That's in our chamber, 30 people that just stepped in within 15 minutes. They were at 12% O2, which is a PO2 that's equivalent in the Margarita hut. And the open symbols is hypobaric hypoxia. That is in the Margarita hut. So these people, again, 30, walked up to the Margarita hut, staying one night at the Nifetti hut. So it took them 24 hours to get there. That's the difference in the exposure. But it's, again, after 16 hours of exposure. And you see no item of the AMSC score, and not the global score here, is any different when people that were in normobaric or hypobaric hypoxia for 16 hours. Also in the Lake Louise score, in the self-assessment, there was no significant difference. The only difference we have here in the clinical assessment is edema you only had in hypobaric exposure at the Margarita hut, which may also have to do with exercise that you had to get there. So, in my opinion, it's more or less equivalent. It doesn't matter whether it's normobaric, hypobaric exposure. And let me summarize the settings. Again, expedition trekking. Advantage is adventure. Acclimatization studies, big numbers you can examine. And of course, it's an ideal setting also for drugstores. Hut-based technology, you have better possibilities, investigational technology. You can study adjustment, you can study physiologic responses to acute exposure or illness. And drug studies, of course, again. And in the chamber, technology, you have modern hospital technology. You can use almost anything you have in the hospital. And it's the only setting where you can have a blinding or double blinding. So these is a summary of the specifications and the advantages, disadvantages of the settings. Now, when you look at adventure here, in the hut-based studies, I mean, it's much less, but there is still some adventures. And let me give you a few examples. One is, this is Monte Rosa. Monte Rosa hut is down here. This is the Margarita hut. And when the first time we went up from the Monte Rosa hut to the Margarita hut, there was a lot of new snow fallen here in the Obere Platier. And we had some people with us that were scientists but had never been on a mountain, and one of them disappeared in this crevasse. And no problem, Oswald Oelz and myself got him out rapidly. Problem was then, it was foggy, we didn't find the hut. And we were not prepared to do a bivouac because we had all left our equipment for the helicopter flight. So we survived that night too, reached the hut. But it was quite traumatic. Another example was Actually, we spent the night somewhere in the crevasses. And in another study, I got a phone call from the Nifetti hut. The technician that should do the examinations in the Nifetti hut is mountain sick. Was the first stage should start. The only one who knew what's to do there was me, because I had designed the study. So it was foggy outside. And so I talked to the mountaineers arriving, and they said, oh, I asked them, how is the situation? They said, oh, it's just a little bit covered on top. So I took my skis, took off, and then I was about somewhere here. It didn't leave. It was still foggy. I mean, there was no release, no clearing. And then I wanted to take out my map. And I realized that my map was not in my rucksack. I had a compass, so I could follow. It was windy. You didn't see the tracks a lot. But what helped me to come to this place here, which is the Liesjoch, is the yellow patterns along the line. You know, it really marked. It helped me to find it. When I was here, fortunately, there was a tent. Someone was bivouacking. So out of the fog, I walked to these guys. Said, "Do you have a map?" And then I took the direction, because I wanted to go to the Balmenhorn hut, because on the lower side there are some big crevasses. And I set the compass. But once I got to the Balmenhorn hut, it cleared, and I could ski down. And very ironically, we never published any of the data we collected at the Nifetti hut. We didn't need it. Other type of adventure is environment. You see here, it's summer. You have clouds moving up, summer clouds, and you can have lightnings. And the Margarita hut is a Faraday cage, and it's often hit by lightning. And one time, we had one that was doing filtration, and one of the extension cords was running outside the hut. And with the lightning, he did his last measurement, and then the apparatus went out. It was very challenging to get him within 3 days up a new equipment. And we only lost one group, and in the paper you see the number of observations varied because of dropouts, as mentioned above, and an intercurrent technical problem with the filtration apparatus and electronic lighting equipment was destroyed by lightning. Last adventure is demanding projects and equipment. This is what the echocardiography machines looked like about 20 years ago. Today you can do this all on a laptop. But we had a lot of problems getting these machines in and out of the hut. It was about, I don't know, what was it? Close to 100 kilos probably. The Eula Packard. Yeah. No, it was not 200. Okay. Yeah, we felt. So you see, it's really there it goes. Thanks to Erd Zermatt. The biggest instrument we ever had in the Margarita hut was a new gamma camera of nuclear medicine department of the Inselspital. They were so kind to send and to have a first go at the Margarita hut. And you see, it was 150 kilos, and you see what the helicopter pilot has to do up here. It was above the stairs, because we wouldn't have brought it up to the stairs. We couldn't have carried it. Here it's in a room, and we looked at lung perfusion in this patient here that has pulmonary edema, and you see the highest perfusion is in the edema. Then we gave 40 ppm NO, and what you see is a shift from the perfusion away from the edema to the edema-free areas, compatible with the concept of overperfusion. Another challenging study was, I thought Robert Naya would be here, though I really want to show it. It was assessment of capillary pressure by a right heart catheter, single occlusion technique, and they showed that capillary pressure is increased in high altitude pulmonary edema. Now let me briefly go Do you give me 5 more minutes? To the cause and effect issue. You still can read it today, that fluid retention is associated with AMS and possibly might be caused. I mean, we contributed to this myth. But we were aware that there are a lot of confounders. I mean, what you see here is urine volume lower in AMS and sodium excretion lower in AMS at the Margarita hut during 4 days. But you have major confounders, which is exercise and the effect of training status on fluid balance handling, and you have loss of appetite with AMS, so you take in less sodium. So what we did, we had a 5-day run-in phase in Lausanne, and they had the subjects had a controlled diet with 150 millimolars of sodium per day. And when they were in a steady state regarding sodium balance, we avoided exercise, put them on a train to Sion. From Sion, they were flown to the Margarita hut. In the Margarita hut, from the helicopter straight to the bed. And what you see, and we got the same AMS response as always. And what you see here is urinary flow. This is what in Lausanne, and this is during 44 hours in the Margarita hut. An initial response, perhaps it's high altitude diuresis, no difference between the two groups. And this is sodium excretion, no difference between the groups. So AMS develops independent of acute mountain sickness. Another issue, that's how I started. I looked at coagulation, and what we were interested in fibrinopeptide A. That's a small peptide of 14 amino acids that's cleaved by thrombin, initiating polymerization of fibrin. When you have increased FPA, you have in vivo fibrin formation. So the first time after we had survived the crevasse fall and the bivouac outside, we had 4 people, we found 4 mountaineers with HAPE in the Margarita hut. We looked at blood coagulation, and fibrinopeptide A was clearly without overlap increased over controls, with and without AMS. And by the way, those were really advanced cases. The PO2 on average of these 4 was 23, the lowest was 19. And the saturation is not calculated, it's measured arterially. It was on average 48%. So severe illness. And to me, the question arrived, I mean, these advanced cases, is this a consequence of HAPE, or is it a factor that contributes to HAPE? And this actually, I wanted to go into practice at that time. Kept me in because I wanted to solve this solution, this question. And I designed a study. I read the paper of Hultgreen. I knew that likely they would get HAPE again. So I got people from mountaineers that had developed HAPE before. We took them up in 4 days, in 2 days to the Margarita hut, and observed them for about 3 days up there. And we had HAPE susceptibles. And 6 of these 9 HAPE susceptibles had HAPE again. And we were very early in HAPE. And what we saw is, this is before beginning HAPE, and those were the advanced cases. There is no fibrin formation in vivo before. And this fellow you see here, he was the one with the most advanced HAPE. He had a slightly increased value above the normal value of 1.8. We furthermore looked in the hospital of FISP at coagulation in hospitalized patients, and they had increased fibrinopeptide A. So fibrin formation is a consequence and not a cause that leads to HAPE. Last example. You all have heard of this famous study. That's the Windy Corner tents of Peter Hackett on Mount McKinley, and they lavaged people that had HAPE on Mount McKinley, and what they found is increased leukocytes, thromboxane B2, leukotriene B2 protein, so inflammatory response, increased permeability. Same was reported from hospitals in Japan, looking at hospitalized patients that have been brought down. This contrasted with all we had looked in markers of inflammation, systemic inflammation in HAPE susceptibles that we had seen in the Margarita heart. So the only thing left to show that there is really a difference, that this is a consequence, not a cause, is doing bronchoalveolar lavage in the Margarita heart. And Eric Svensson, who had already been involved in lavaging on Mount McKinley and had done a sabbatical with us, did the lavages. And we were very lucky in this study. We had 3 subjects with beginning HAPE on the morning when we lavaged after the first night. This is one we lavaged. This is the fluid we got out. And no granulocytes, no signs of inflammation. And so and a lot of erythrocytes and albumin. And the albumin concentration really depends on how big your pressure is. Same thing for erythrocytes. You see the same plot. So the higher the pressure, the greater the leak, but no inflammatory response. So conclusion is HAPE is a pressure-induced, non-inflammatory edema. I hope I could convince you that it's important. Whatever we measure at high altitude, we have to ask ourselves, is it cause or is it consequence? And this is also particularly relevant for omics studies. When you look at metabolomics, what's the other omics? Genomics is less. Metabolomics and proteomics. It is important in which phase of the illness you look at these pathways. And when I look at studies coming from China, it's a pure phenotyping first, and second, don't even mention or consider when it was measured. So I think it's very important for that reason too. My conclusion, competitive research involves testing a reasonable, innovative hypothesis, selecting the appropriate study design and setting, and applying the best available and feasible method to tackle that problem. And so you have several options. I've shown you the advantages and disadvantages of what you can choose. But you should be driven by the hypothesis and by your questions. And then, of course, standard reporting is also important. And with that, I close.